Welcome to the StudyNeuro Neuro Lecture Series. In this session, we'll guide you through a step-by-step bedside examination of cranial nerves 8, 9, and 10. By the end, you'll understand their key functions, recognize common clinical deficits, and apply practical bedside techniques for accurate neurological localization. Cranial Nerve 8, the vestibulocochlear nerve, controls hearing and balance. Cranial Nerve 9, the glossopharyngeal nerve, manages taste from the posterior tongue and the gag reflex. Cranial Nerve 10, the vagus nerve, regulates swallowing, phonation, and autonomic functions. These nerves are commonly affected in hearing loss, vestibular disorders, dysphagia, voice changes, and brainstem lesions. Mastering their examination is essential for effective neurological assessment and clinical localization. Follow youtube.com/studyneuro for more lectures, neuroscience updates, and clinical insights. When examining the vestibulocochlear nerve, the focus at the bedside is hearing. This assessment helps determine whether a patient has normal hearing and, if not, whether the deficit is conductive or sensorineural in origin. Begin with a simple screening test. Assess each ear separately by standing behind the patient and using a whispered voice or a finger rub near the ear. Ask the patient to repeat the words or numbers they hear. This quick step tells you whether hearing is grossly intact and whether further testing is needed. If a hearing deficit is detected, move on to tuning fork tests. Start with the Rinne test to compare air conduction and bone conduction. Place the vibrating tuning fork on the mastoid process and then position it just outside the external auditory canal, asking the patient which sound is louder or lasts longer. This comparison provides key information about how sound is being transmitted. Next, perform the Weber test by placing the tuning fork at the midline of the forehead or vertex. Ask the patient where they hear the sound best. This helps determine whether sound is being perceived symmetrically or is lateralized to one side. In a normal examination, whispered sounds are heard clearly in both ears. Air conduction is louder and longer than bone conduction on the Rinne test, and the Weber test does not lateralize to either ear. Clinically, it is important to remember that Weber and Rinne tests are only necessary if the initial hearing screen is abnormal. In conductive hearing loss, sound lateralizes to the affected ear on the Weber test, and bone conduction equals or exceeds air conduction on Rinne testing. In contrast, sensorineural hearing loss causes sound to lateralize to the unaffected ear, while air conduction remains better than bone conduction. Together, these findings help localize pathology to the external or middle ear versus the inner ear or vestibulocochlear nerve. When assessing vestibular function, you're essentially evaluating how well the inner ear and its central connections are maintaining balance and keeping the eyes stable during head movement. This is particularly important in patients presenting with dizziness, vertigo, or unsteadiness, where the key question is whether the problem is peripheral or central. Start by simply watching the patient. Even before you move their head, observe the eyes at rest. Spontaneous nystagmus can be an early clue to vestibular pathology. From there, ask the patient to follow your finger slowly. This allows you to assess gaze stability and detect gaze-evoked nystagmus, which often points towards central involvement. One of the most informative bedside tests is the head impulse test. Ask the patient to keep their eyes fixed on your nose, then make quick, small head movements to either side. In a normal response, the eyes stay locked on the target. If you see a corrective saccade, this suggests impaired vestibulo-ocular reflex function on that side. Next, assess balance more globally. With the Romberg test, you're looking to see whether the patient can maintain posture when visual input is removed. Increased instability once the eyes are closed suggests a vestibular or proprioceptive contribution. Watching the patient walk adds further information. Veering or imbalance can reinforce vestibular dysfunction. In a normal examination, eye movements are steady, gaze remains stable during head impulses, posture is maintained with eyes open and closed, and gait is coordinated. Interpreting these findings together is what matters most. An abnormal head impulse test combined with nystagmus usually indicates a peripheral vestibular lesion, whereas a normal head impulse test in the presence of other neurological signs should raise concern for a central cause. The key takeaway is to rely on observation and pattern recognition. Vestibular testing is less about isolated maneuvers and more about integrating eye movements, balance, and gait to localize pathology accurately at the bedside. When examining the glossopharyngeal and vagus nerves, we are primarily assessing the function of the palate, pharynx, and larynx. These nerves are essential for symmetric palatal movement, normal voice quality, and safe swallowing. Begin by asking the patient to open their mouth and say, "ah." Observe the soft palate as it elevates and the uvula for symmetry and midline position. Listen carefully to the patient's voice, noting any hoarseness or nasal quality, which may suggest vagal dysfunction. Testing the gag reflex is optional and should only be performed if clinically indicated. If you do test it, gently touch the posterior pharynx with a tongue depressor or cotton swab, and always explain the procedure to the patient beforehand. Throughout the exam, compare movements on both sides to identify any asymmetry. Normal findings include symmetric elevation of the soft palate, a midline uvula, a clear, non-hoarse voice, and a present gag reflex if tested. Clinically, asymmetric palatal elevation or uvular deviation indicates ipsilateral vagal weakness. Voice changes such as dysphonia or nasal speech also point toward vagus nerve involvement. While absence of the gag reflex alone is not always pathological, these observations are important for localizing brainstem or bulbar lesions and for assessing swallowing safety. To wrap up, cranial nerves 8, 9, and 10 control hearing, balance, swallowing, and speech. Bedside exams can detect vestibular problems, dysphagia, voice changes, and brainstem lesions, and understanding their anatomy helps with accurate lesion localization. In Part 4, we'll cover CN11, the accessory nerve, for neck and shoulder movement, and CN12, the hypoglossal nerve, for tongue function. These nerves are essential for comprehensive neurological assessment. Thanks for watching. Comment your key takeaway and like, share, and subscribe at StudyNeuro for weekly neuroscience and clinical tutorials.